for a prescription drug. These ads are legal in most countries, but in the US, they're everywhere. On average, 80 of them air every hour on American television.
Ask your doctor.
Ask your doctor.
My doctor told me.
Ask your doctor.
The American Medical Association, a major group of doctors, has called for a ban on these direct-to-consumer ads. But there's a case to be made for them too. So today we'll take a look at both sides. First, a little background. Before the 1980s, prescription drug commercials were unheard of in the US. Drug companies focused their marketing solely on doctors, and they didn't want to hurt those relationships. When asked by Congress in 1984 if direct-to-consumer advertising should be allowed, one pharmaceutical executive said,
"The direct advertising of prescription pharmaceuticals to consumers would be detrimental to the pharmaceutical industry, and more importantly, a potentially disruptive element in our medical delivery system as a whole."
And an executive at Schering-Plough, which is now part of Merck, said,
"We have serious concerns about proposals to allow advertising directly to patients. We do not believe it is in the public health interest. Indeed, we believe that in most cases, it cannot safely be accomplished."
Needless to say, they changed their minds. At the time, there was a larger cultural shift in healthcare toward empowering patients to make decisions rather than just listening to their doctors. And advertisements fit with that trend. Drug ads started appearing in print publications, but there was still another thing keeping them off of TV, and that was FDA's regulations at the time. They were interpreted as requiring ads to include all the information about the drug's risks and side effects, which simply wasn't feasible to do in a TV or radio commercial the way it was in a magazine. There was a bizarre loophole, though. The ads didn't have to mention the drug's risks if they also didn't mention the disease or the condition that the drug was supposed to treat. Here's what that looked like in an ad for Claritin back before it was available over the counter.
It's time. It's time.
Don't wait another minute for Claritin.
Claritin. I'll ask my doctor.
It's time to see your doctor.
Mr. Wilkie, the doctor will see you now.
At last, a clear day is here.
Confused? Yeah, everyone was. So in 1997, the FDA clarified that the industry could run the full drug ads and wouldn't have to give all the risk information from the label as long as they included the major side effects and referred viewers to another source for the rest. That's why the commercials direct us to phone numbers or print ads. Come for the pharmaceutical fine print, stay for the secret to crisp contact and soggy conditions. That new FDA guidance removed the main barrier keeping drugs off of television, and you can guess what happened next. Spending on ads quadrupled by 2004, and now we know the names of prescription drugs like we know the names of cars and clothing brands.
Lunesta, Xanax, Celebrex, Flomax, and HGH.
And as of Thursday, Lipitor.
Oh, and if you have trouble sleeping, Marla has Ambien. I prefer Lunesta.
Lipitor, baby aspirin, Flomax.
Flomax? And some Cialis! I'm just assuming.
So that's how we got here. Drug ads are now the most frequent form of health communication that most Americans see. So what does that mean for public health? Are those prescriptions going to the right people? Or are they going to people who probably won't benefit from the drug? People for whom the potential risks outweigh the potential benefits? Well, the answer seems to be both. A clever experiment in 2005 tested this by sending actors to real primary care doctors.
We helped them make appointments. We generated fake insurance cards. We did this all with the permission of the physicians in advance, but the physicians didn't know which of their new patients that were coming to see them were real patients versus actors.
In half of the visits, the actors reported symptoms of depression. In the other half of visits, the actors said they were feeling down after becoming unemployed. The study authors called this an adjustment disorder.
That's essentially a condition in which watchful waiting is probably most appropriate, and that, in the view of many, an immediate prescription for antidepressants would be excessive.
In some visits, the actors mentioned seeing an advertisement for Paxil on TV. That's an antidepressant. In others, they didn't bring up medication at all. And the doctors seemed to take patients more seriously if they mentioned seeing the Paxil commercial. They were more likely to refer patients to a mental health consultation and much more likely to prescribe an antidepressant. That may be a good thing for those with major depression who might benefit from a medication, but it's more questionable for those with a more temporary condition.
For us, it typified the double-edged sword which direct-to-consumer advertising represents.
This study and others have shown that doctors can be persuaded to broaden the scope of who gets treated with drugs, and advertisements often seem designed to encourage that. Take Androgel. It was approved to treat men with hypogonadism. That's extremely low testosterone levels due to injury or disease. But here's how it was promoted by Abbott.
Millions of men 45 and older just don't feel like they used to. Are you one of them? Remember when you had more energy for 18 holes with your buddies? More passion for the one you love.
Some middle-aged men don't feel like they used to? You don't say. A study looking back at 10 years of testosterone prescriptions found that only half of the men had been diagnosed with hypogonadism in the previous year. Drug ads give the industry an incentive to make healthy people feel unhealthy.
Latisse is the only FDA-approved prescription treatment for inadequate or not enough lashes.
And they contribute to unrealistic expectations about what pharmaceuticals can do. So what's wrong with that? Well, every single drug comes with risks. Big ad campaigns are usually for newer drugs, for which not all the risks may be known yet. In the case of the painkiller Vioxx, a massive ad campaign led millions of people with arthritis to switch to Vioxx instead of sticking with older drugs like ibuprofen.
Ask your doctor today about Vioxx and find out what Vioxx can do for you.
Vioxx was more expensive and not actually more effective. And
the manufacturer of Vioxx has recently pulled this popular arthritis drug from the market over health concerns.
Merck withdrew the drug after it became clear that it increased the risk of heart attacks and stroke. A Kaiser Permanente study later confirmed that ad exposure was linked to inappropriate prescribing of Vioxx and a similar drug called Celebrex. So that's a worst-case scenario. But there's also an argument that these ads can be good for public health.
There are many diseases for which people don't seek treatment. So if you can educate through direct-to-consumer people about the fact that this can be treated, you will get a better outcome for everyone.
In their view, more communication with your doctor is always a good thing, and it's up to the doctor to make the right prescribing decisions. Surveys of the public have confirmed that drug ads prompt people to visit their doctor, in some cases for diabetes, hypertension, depression. These are conditions that are thought to be undertreated. And in the case of the HPV vaccine that's now recommended for all preteens to prevent cervical and other cancers, Merck's ad blitz for Gardasil probably reached more people than a government communications effort could. And whatever you think of erectile dysfunction drugs, they got men to see their doctors and undergo the required heart screening, potentially catching problems not yet treated. But the strongest argument in favor of drug ads may be the legal one. The Supreme Court ruled in favor of prescription drug advertising back in the 1970s when the state of Virginia tried to prohibit pharmacists from advertising their prices.
We further hold that so-called commercial speech is not wholly outside the protection of the First and 14th Amendments. The individual consumer and society in general may have strong interest in the free flow of commercial information.
It was the first time that the court said advertisements were entitled to free speech protections. There was only one dissenting justice at the time, William Rehnquist, who Ronald Reagan would later appoint Chief Justice. In his dissent, Rehnquist wrote a kind of uncanny prediction of the type of commercials that would come decades later. Don't spend another sleepless night. Ask your doctor to prescribe Seconal without delay. Rehnquist worried that ads would, quote, generate patient pressure on physicians to prescribe drugs, and that they'd end up being advertised on television. And as we now know, for better or for worse, that's exactly what happened.
In 1996, 56 volunteers took part in a study to test a new painkiller called trivaricaine. On each subject, one index finger was covered in the new painkiller, while the other remained untouched. Then, both were squeezed in painful clamps. The subjects reported that the treated finger hurt less than the untreated one. This shouldn't be surprising, except trivaricaine wasn't actually a painkiller, just a fake concoction with no pain-easing properties at all. What made the students so sure this dummy drug had worked? The answer lies in the placebo effect, an unexplained phenomenon wherein drugs, treatments, and therapies that aren't supposed to have an effect and are often fake miraculously make people feel better. Doctors have used the term placebo since the 1700s, when they realized the power of fake drugs to improve people's symptoms. These were administered when proper drugs weren't available, or if someone imagined they were ill. In fact, the word placebo means "I shall please" in Latin, hinting at a history of placating troubled patients. Placebos had to mimic the real treatments in order to be convincing, so they took the form of sugar pills, water-filled injections, and even sham surgeries.
The placebo effect, when something with no known therapeutic value can actually make people feel better. It's a great trick our minds play on us, that by believing and expecting something to work, it actually does. But what's weird is that the strength of the effect can differ for some really strange reasons. For example, the same placebo can treat pain half as well as aspirin, while at the same time treating pain half as well as morphine. Morphine's a much more powerful painkiller, but a placebo is half as effective as both? Saying a placebo will reduce pain reduces pain, but saying that the same placebo will increase pain increases pain. Believing that a placebo will make you feel better will make you feel better. Believing that it won't has the opposite effect. Now, placebos aren't just pills. They can be creams, injections, surgeries, or drinks. You can even get placebo buttons. They don't actually do anything, but they sure as hell make you feel like you're in control. But not all placebos are equal. The effect of the placebo is bigger when the pill itself is bigger, or if you have 2 instead of 1, or 2 once a day instead of 1 twice a day. And a capsule will usually beat a pill, and a syringe will usually beat a capsule, and anything with a big ass science machine can outperform any of them. A plain pill works worse than a branded one. A discounted pill works worse than a pricey one, and even a pill in a plain box does worse than one that's all shiny and shit. Placebos that are blue work best as downers, and placebos that are red are better as uppers. Studies have shown that people who take their meds on a regular basis are less likely to die than those that don't, even if those meds are all placebos. You can even get addicted to placebos. In one study, a group of women took placebos for more than 5 years. 40% of them suffered withdrawals afterwards. In fact, the effect of placebos can be so strong that some people want them banned from sports. But I mean, how would you even test for that? Placebos don't even seem to work from place to place. For example, in Germany, using a placebo to treat ulcers works better than anywhere else in Europe. But using a placebo that treats hypertension doesn't work nearly as well as it does for its neighbours. Now remember that all of this is about comparing things that both have nothing medically effective in them, which goes to show that a placebo isn't about what's in it, but about the beliefs that we load onto it. Our minds create the medicine, and that is pretty freaking weird.
One of the ways that I try to help my patients understand this is by talking to them about placebo studies, because in the effects of the placebos, we see just how powerfully the mind can influence our organ systems. Let me tell you a little bit about what's known about placebos. Placebos, you know, are inactive substances, usually inactive, things like sugar or starch pills, that are given to people with some suggestion that they might help. The dose-response curve of most placebos is remarkably similar to aspirin, ibuprofen, or acetaminophen. It reaches maximum efficacy in 20 to 30 minutes, and then it tends to trail off in its effectiveness after 4 to 6 hours. Now, active placebos are much more effective than passive placebos. An active placebo isn't just sugar or starch. It's some medicine that in some way causes some response in the body which is uncomfortable. So it's like giving somebody niacin that will make them flush, or giving them something that will give them a dry mouth, something so that the person can feel a change in the body, even if that change in the body has nothing to do with the purported effect of the placebo. To get really effective, though, it helps to move beyond pills. Injections tend to be much more effective than pills, and active injections, in other words, injections of substances that change how we feel in the body, are more effective than injections of saline. And as we'll soon see, the really powerful placebos are surgical. Let me give you some examples of the remarkable power of placebos. One of them, that dates from the 70s, involved treatment for temporomandibular joint disorder, which is pain that occurs in the joints of the jaw muscles and the jaw joint. It was thought in the 1960s and the 1970s that the epidemic of temporomandibular joint problems that was happening at the time were probably due to the deterioration of the joints. And oral surgeons were busy putting replacement kind of discs into the joint. They used Teflon, for example, for some of them. But the problem was that the Teflon started to deteriorate and they had big problems. So one enterprising group of dentists who thought, you know, I don't think this is about the structure of the jaw. I think this is about the patient's attitude toward the TMJ symptoms. They decided to try an intervention called sham tooth grinding. And what they did was they created a dental instrument that was, about 1 inch in diameter and maybe 6 or 8 inches long that vibrated a lot. And what they did was they told patients that they were going to realign their bite. And they would put this instrument into the patient's mouth and shake, rattle, and roll. They basically vibrated for some 40 or 45 minutes, after which they told the patient, we think we've done it. We've reconstituted or restructured the shape of your teeth so that you should have a better bite now, and this should resolve the difficulty. 64% of the patients who had sham tooth grinding had total or significant relief a year after simply one application of the procedure. Some studies are even more startling than that. I want you to reflect, if you were alive during the second half of the 20th century, as many of you probably were, roughly the period from 1950 to 2000, which group do you think of as having been more powerful in our societies? Doctors or lawyers? Take a moment to think about that. When I ask audiences, usually most people vote for the lawyers. But I think that's actually a recency effect. I think they're remembering around the year 2000. They're not really remembering what things were like in 1950. There's a common surgery that was done for angina pain. Angina pain, as you probably know, is pain that comes from partial or greater occlusion of blood vessels in and around the heart. And it's a kind of chest pain that comes from this. And it was found that they could do something called mammary artery ligation to resolve this. And what they would do is the following surgery. First, they would open up the chest. They made an incision all the way from the collarbone down most of the way to the navel. Then they would saw through the breastbone. They would retract the rib cage, and they would tie off this artery, the mammary artery, and then sew people back up again. And the logic behind this was that by tying off the mammary artery, you'd induce the heart to grow collateral vessels. It was kind of like creating nature's own bypass, if you will. And it used to work pretty well. They got 80 to 90% success rate of people recovering from angina pain with the surgery. The only fly in the ointment was that every once in a while, somebody would subsequently die and would have an autopsy. Not usually die from the surgery, but die from other causes. And upon autopsy, they never found the collateral vessels. So that raised the question, what's up? What could be causing the relief from the pain? One enterprising group of doctors thought, let's test this more scientifically. And they took the next series of patients that came into their hospital who were appropriate candidates for mammary artery ligation, and they did most of the surgery as usual. They did the incision from the collarbone down, they sawed through the breastbone, they retracted the rib cage, but they didn't actually touch the heart. They just sewed people back up again and told them that they had had successful mammary artery ligation. They then followed these patients and saw what happened once they healed, and what they discover? 80 to 90% success rates. Same success rates that they had with the real mammary artery ligation. Now you as a modern person may be thinking there's an ethical problem with this. And indeed, perhaps there was an ethical problem. It's a little hard to find this journal article. It just so happens that the journal article reporting on the surgery was published by a little publishing house that is literally just down the road from where I live in Massachusetts. The name of the journal, you've probably never heard of it, it's called the New England Journal of Medicine. And it was published there in 1959 without a single mention of ethical issues. The next year, it caused quite a stir. Another team of doctors did the exact same surgery on a new group of patients, also not telling them about it. That was published in the American Journal of Cardiology in 1960. And then the lawyers got involved. They started saying, you can't do that. These are human beings. You have to give informed consent. Which, while I'm very sympathetic to that argument, entered us into the dark ages. Because then, how are we to know going forward when a surgical intervention seemed to be helpful to people and eliminate pain or reduce pain? How could we know whether it was a placebo effect or the effect of the surgery? Frankly, we couldn't. Until the year 2000, when we started coming out of the dark ages because of a team of enterprising surgeons and researchers at the University of Texas. Because they actually came up with a plan by which they could do placebo-controlled surgery and get it past an institutional review board because it was an ethical plan. And here's what they did. They took subjects and they told them in advance that they were going to be randomly distributed to either arthroscopic debridement, which meant making little incisions around the knee to do arthroscopic surgery and smoothing out the structures under the kneecap, arthroscopic lavage, which meant washing out the structures under the kneecap, or the incisions only. That was the placebo group. And they followed these folks for 2 years. The study was very well done because what happened was the surgeons did the surgery, but then they never saw the patients again. The researchers followed them in the postoperative period and then on over the next 2 years, and the researchers were completely blind to the condition. They had no idea who had had the surgery and who had not had real surgery but only had placebo interventions. Now, because of my interest in placebo research and because I use it clinically to help patients understand that the mind is so powerful in its effects on the body, I was following the study very closely. And at the end of the study, it got a lot of media attention. And I was listening on National Public Radio while they interviewed one of the subjects who had been in the study. And this subject said that he was very glad to have participated because starting about a week or so after the surgery, once the incisions healed, he had felt much better and he'd actually been free from knee pain for the last 2 years. And what he said was, I think the surgeons were top-notch because clearly they cured me. But the researchers, they were very sweet, very nice, supportive people, but they weren't as competent as the surgeons. The reporter said, what makes you say that? And he said, well, the other day when they finished the study, the researchers got all confused. They thought I was in the placebo group. Everybody improved. Real surgery had no advantage over the placebo at any point during 2 years following surgery. This is very powerful stuff. Let's look at acupuncture. These effects aren't simply limited to surgery. In 2005, there were 2 large, high-quality trials in patients with headache. They found little difference between the effects of acupuncture and placebo acupuncture, but a very big difference between placebo acupuncture and no acupuncture at all. It turned out that placebo acupuncture was pretty much as good as real acupuncture. Then in 2002, there were 131 consecutive lower back pain patients at a university in Germany were randomly assigned to 3 groups. And each group received active physiotherapy across the whole study. The control group got no further treatment. There was an acupuncture group that got 20 sessions of traditional acupuncture, and then there was a sham acupuncture group that got 20 sessions of sham acupuncture. Now, sham acupuncture is an interesting procedure. They stuck in needles, but they stuck them in superficially, and they stuck them between 10 and 20 millimeters away from the true acupoints outside of the meridians. And the needles weren't stimulated, as they often are in real acupuncture. They found significant improvement in traditional acupuncture for chronic low back pain compared to the routine care, the physical therapy, but no difference from sham acupuncture. Sham acupuncture also worked just as well. Josephine Briggs is the doctor who's the director of the National Institute for Health, the Center for Complementary and Alternative Medicine here in the United States, and she's come to the conclusion that acupuncture is a particularly effective placebo intervention. It's so well designed with a whole ritual. It involves breaking of the skin, which we know works so much better than simply taking pills. It requires time, and the person has a full body experience when they go in for acupuncture. Perhaps even more remarkably, we now know that placebo interventions will work even when people know that they're getting a placebo intervention. There's a Center for Placebo Studies in one of the Harvard teaching hospitals, and they took 80 patients who were randomized to either open-label placebo pills. In other words, they were told this. They were told placebo pills are made of an inert substance, like sugar pills, and they've been shown in clinical studies to provide significant improvement in irritable bowel syndromes through mind-body self-healing processes. And the subjects had irritable bowel syndrome. So they thought, okay, this can work. But they were told that these are sugar pills, and they were told the truth, which is that sugar pills do help with this disorder. So they either got the placebo pills or they were in no treatment control group that got the same quality and type of interaction with the providers, but no placebos. The people with the open label placebos had significantly higher global improvement scores on their irritable bowel syndrome symptoms at both 11-day midpoint of the study and at the 21-day endpoint. What was fascinating to me, I was following this on the radio also, was that the patients after the study who had gotten the placebo pill said, "This is great, thank you, I'm glad I participated. Where can I continue to get the placebo pills?" And the researchers said, "Well, they're just inert. You could use Tic Tacs." And the subject said, "No, no, no. I want those placebo pills. Those are what worked for me." And they were actually upset when the researchers couldn't provide them because there were various ethical and legal strictures that made it so that they wouldn't do it. Okay, so these stories are presented to you, and I present them to my patients so that we can get an idea that, wow, the body and the mind are closely interacting with one another, and the mind is extremely powerful in the effects that it can have on our subjective experience of the body. Now, illness anxiety is a component of all of these different disorders. And it's unavoidable. One of the reasons why the Buddha supposedly left the palace and went out into the world to follow spiritual practices was because of illness anxiety. And illness anxiety is actually remarkably easy to generate. Let's try some right now. Take a moment, and if you can, close your eyes. And I want you to sense whatever's happening inside your head right now. And see if you can sense a little bit of discomfort, maybe a kind of pressure that's there. Just try it. See, can you feel any pressure in your head? And see if you can sense a kind of pressure that if it were to get more intense, might start developing into a headache. Uh-oh, it may be happening. We find that people who live with folks with brain tumors have a lot more headaches than people who don't live with folks with brain tumors. And folks who have had chronic headaches before rivet on any sensation of pressure, and it becomes a problem. It expands into a headache. Or consider this. Imagine that you just learned that there's something wrong with your laundry, and there's been a lice outbreak, and there's some in your clothes. And just feel what's happening in your body right now, and notice whether you sense any itching anywhere. Maybe around the scalp, maybe somewhere else. Uh-oh, it could just be lice. Oh, I got another notice. It said it actually doesn't affect your laundry, just other people's laundry. It's important to undo hypnotic suggestions. So you probably notice, if you try those experiments, that all it takes is bringing anxious attention to a part of our body, and we can start to feel sensations in that part of our body and start to worry about them. And these things can get amplified very easily. Now, we have two basic reactions when we experience something untoward in the body. When we're younger, and it helps if you come from certain ethnicities, you may think it's probably nothing. You may think, oh, this is just a coming or going sensation. I don't really have to worry about it. But if you're older, you may start to think it's probably something serious. And this happens too if you grow up in an ethnicity or a family that's very focused on medical disorders. One of my favorite cartoons about this has an anxious woman, and she's reading the big book of horrible rare diseases. Near her feet is the Merck Manual, A Child's Garden of Maladies, Lockjaw Monthly, and all these other reading materials, which now that we have the internet, can be any of us, because we can all search online for a symptom and get some pretty scary possibilities about it. What happens is illness anxiety itself can become the problem. And it can be very tricky to figure out which error to make. You wouldn't want to ignore a grapefruit-sized growth coming out of your neck and think it's probably a zit, but nor do we want to rivet on and pay attention to every one of these different sensations when they arise, because doing that can make any of these sensations turn into one of these disorders. Now, The biggest challenge, or I shouldn't say the biggest challenge, but an important challenge to keep in mind when we're treating for ourselves or others these stress-related disorders is to realize that even if we're a good mindfulness student and even if we take a good attitude toward these disorders, we can still run into trouble. Now, no matter how good we are as a mindfulness student, we're all headed for the same place, and the bodies are going to fall apart eventually. And some of these disorders are resolvable and some are not, and we don't want to fall into the trap of blaming ourselves for a disorder that we can't resolve.